Thank you. There we go. That's better. Thank you. I really appreciate that. Thank you also to Adrian. We have been partners in crime for a while here. And I'm thrilled to be here. I didn't even understand maybe half a year ago that this was really in the planning. And do you understand that not only am I excited to be here, I'm sorry, but I'm just really going to challenge you. I apologize. I just can't help it. It's like being caged up there. It just doesn't work for me. So I'll buy you a drink later, something, whatever it's going to be, a coffee, whatever it is. Not only am I thrilled to be here, something that I didn't even understand was being boiled, but also do you understand that you're lucky to be here? Because do you realize the conference was sold out early and there was a big waiting list? So we're actually among the people who just jumped first to try and get in and get the information that we're getting here today. It shows that the demand in Pennsylvania is so high, which is thrilling for me in many, many ways. As Judy had said, I've been working with Judy, with Adrian, with other people here in Pennsylvania for several years now. Adrian is one of the amazing executive directors of an LGBT community center around the country. There's about 200 of them all together around the country. And I think it was probably maybe 2.5 years ago or something like that we were talking at one of these meetings. And we were talking about what was happening around the country with the community centers who decided to expand into health. And the truth is there are a lot of community centers who weren't doing a lot of health. They were doing, honestly, what are they doing? Maslow's hierarchy, they were doing critical life support issues. So many community centers were doing youth support groups. They were doing suicide prevention. We are still calling that health, absolutely. And they were being a community nexus for the people. But a lot of them had not expanded into health formally to do that kind of work. And so as I was first talking with Adrian, I'm like, we got to think about health. It's a huge issue. It's not just for health centers because a lot of the health that happens with the LGBTQA allied communities happens because of our social circumstances, not our physical circumstances, right? We all have the same biology or similar biology. Our biology is about 95% very similar. It's only about 5% different across all the human species, interestingly enough. But we realize now that most of what happens to all of us is because of our social determinants of health. And the queer populations have very different social determinants of what our health status is. So that means that organizations like Bradbury Sullivan Community Center are really well positioned to intervene and break the chain of the cycle of what happens to us socially and what then results in what kind of specific health issues we have. And of course, the one that, at that point, I ran a national LGBT cancer and tobacco control network for the federal government, and it was focused on LGBT issues. So we talked a lot about what might happen related to both tobacco and cancer. And it was through that Judy and I had a relationship long before that. We worked together for many, many years. And that I introduced the two of them. They started to work together. And I was very pleased that one of the things that many states had talked to us about was the issue of data. We don't have data because most often LGBTQ questions are not included on the standard needs assessments, on the federal surveys. I don't know if you heard, but actually under the new administration, who shall not be named, they're trying to take LGBTQ questions off of 2 aging surveys very recently. So even after we fought hard to get them on, they're trying to now take them off. We also know that they're not going to be on the coming census yet again, despite the fact that other countries like England and things like that have added them. So as he eloquently said when he was speaking yesterday, without the data, all the chatter don't matter. So we really struggle around those issues. But also, even if we were on some of those surveys, you still don't ask questions that are relevant to us. For example, are you afraid of going to a doctor because you're LGBT? Something like that. That wouldn't be on a mainstream survey. So for that reason, the needs assessments that specifically ask questions that are specific to our communities are particularly illustrative. And I was very pleased, actually, not just that they were interested in doing one of the local needs assessments, but then when Adrian, frankly, knocked that local needs assessment out of the park and I think became one of those, it's kind of nice because I advise a lot of funders as well as the grantees. So I'm kind of on both sides of the fence, as it were, and can see a lot as far as what people both want, what they're able to deliver, what you can do in a community setting. And I think it's probably pretty fair to say that, Judy, for the funding that you gave Adrian to do that initial needs assessment, you were really wowed as far as what they were able to accomplish. And we see this around the country in a lot of LGBT community centers, actually, because we have been working in our communities to figure out how to do behavior change and interventions for decades. So we're the experts at it, of course, right? So we have reach, we have depth, and not only that, but the truth is we've usually been doing it with like 2 shekels and a dream. So we usually have to be really creative on how to figure out how to do it with very, very, very few resources. One of the things that was, that's my own luggage, it's bothering me right now. I'll trip over it a few more times. One of the things that was frustrating to me, though, when I first talked about it, as we were first trying to negotiate that, was I said, okay, well, which one of the community centers have any kind of a contractual relationship with, the health department, with any branch of the health services whatsoever in the state of Pennsylvania? What was the answer? 0. Yeah, none. Nobody had done any formal work with the Department of Health, which is so crazy to think, because here you have a population that is so horribly impacted by social determinants of health and have such adverse health outcomes, and yet there had been no structured partnership before that whatsoever. So one of the first challenges that both Judy and Adrian had to figure out was, how do we do work together? Because you're not one of our contractors. We can't figure this out. Luckily, they were able to get that one taken care of. I think they're good now. But so we had that first needs assessment. Adrian and another community center knocked it out of the park, and I was thrilled to get the call that they actually wanted to expand it to do it around the state. And as I was saying earlier, one of the first things we get as questions from states would be, how do we collect more data? Because we don't have enough on our state surveillance instruments, we don't have enough on our surveys. And so because of that, we had developed a standardized needs assessment template that could be used anywhere in the country. And so this is the 3rd state in the country, out of all of them, to administer this standardized needs assessment for the whole state. And out of the 3 states, this is the one that has gotten the largest sample, the deepest in-reach into the communities, and the largest data set that came out of it. So that puts us in an amazing position to be able to talk more about what is going on with our populations here. Because trust me, I can go to a lot of different states, and what I'm going to quote you would be federal stats. We know this federally, we know this federally, we know this federally. And then you just have to presume that it applies to your state. You're in probably the very top state in the country as far as us being able to give you data about what actually is the circumstances in Pennsylvania, not just federally, that you're going to extrapolate to here. And that's because of a lot of effort that's been done locally. And I really appreciate that, and I think it puts us in such a better position to be able to move forward as a set of communities. Which also means that, nicely, I'm not going to give you stats. You got better stats from Adrian yesterday than I would be able to give you whatsoever. But I will tell you a little bit about, we'll do a little bit more of the talking about the story of kind of what was going on with these data, okay? Because I do these kind of speeches actually a fair amount around the country, which means that I deliberately waited to see what was going on yesterday before I thought about what I might try and talk to you about today. So what I want to do in this time is make sure that we have a bigger picture of what the narrative is, make sure we have a good sense of plugging holes related to pieces in it that are part of this big picture so that we have a good continuous narrative. And then I want us to think about what's happening here, because you've had a huge amount of information be given to you, and some great presenters. Amy, where are you again? You're wonderful. You were? You're wonderful. Amy, you're amazing. And so I think the question really is then, as a state that's already leading the country in data collection, and we're going to go over a little bit about some of the amazing things that you have going on related to the programmatic activities with LGBT health. The question is, what does this state do as far as its path to excellence in this area? And I think that's something that is not anything I can tell you, That's something that we can think about and come up with together. So I want us to think about what the full narrative is, and then what the path to excellence is, and what steps we can take as the people who are engaged with this to get to that path of excellence. Especially because I'm going to leave the state. I'm going to go back to Rhode Island. So if anything here is going to move the ball forward after this conference, it'll be the people in this room making decisions to change their practices. So I'm really going to be interested to hear about what you're thinking related to that. That said, I'll warn you in advance, I am not allowing any time for questions. Why is that? Because I would really love it if you just talked to me during the presentation. When we wait for questions at the very end, it's usually a little bit harder, okay? So yes, go ahead, I love that. Thank you. You're the best. You hear that? She's the best in the room. But don't worry, you can catch up.
One of the things, I had a very sleepless night last night.
Oh,
One
really?
of those existential kind of crises of like, what the hell am I doing with my life kind of nights. And so, like, as someone who helped to run the GLCC for almost 14 years.
The Gay and Lesbian Community Center,
Gay and Lesbian Community Center of Pittsburgh, that's now Pittsburgh Equality Center. We have a name change. I'm sitting here having one of those duh moments of why didn't I ever reach out to the Department of Health? I reached out to Adagio, I reached out to lots of places. And at one point I had a women's health
Can I just
program.
quote you on that to all the other community centers around the country?
Yeah,
because
sorry.
it is
Duh.
sometimes hard to convince them.
But one night I had a grant for doing free mammograms and free gynae exams. And you can imagine that people weren't exactly busting down the doors to get in stirrups.
Yeah.
And then I went home and thought about it. It's like, okay, so what would get me to come, right? I'm a busy woman. I've got things to do. What would get me to come? Massages.
Ah.
Hot wax hand dips.
Really?
Yoga.
I'll trust her on that one.
Meditation. I like the hot wax stuff, right?
Okay.
Meditation, we had drumming. We had a nutritionalist. We had somebody, a dietitian who was doing healthy eating and showing us how to cook and gave us tasty little samples. And it was a whole body kind of thing. And so I started calling them the Women's Wellness Nights. And the doors were filling with people. We had waiting lists. And it took that kind of creativity of thinking, like, what would I actually get out of bed on a rainy, cold Pittsburgh night to go to get better health care? And that's one of those things that, like, and yesterday, the trans buddy system, why haven't we ever thought about having every single hospital having an LGBTQI MOUSC person who's going to be the advocate for better health care? I teach this professionally, and when I am having a health crisis and I'm the only one in that room, I put on that gown and I become the patient that doesn't know anything. And from the moment we put on those gowns, we're vulnerable. Trust me, when I'm the advocate for you, I'm a pit bull. And I need a pit bull when I need an advocate.
Excellent. I love the idea. Absolutely. So the epiphany had to do with why don't we do more right now and put some specific plans in action, particularly like the buddy system as a possibility. I think that's great. Okay, let's hold it down there as one of the ideas out there that we can continue to act on. So please follow the lead. Talk to me through all of this, okay? Yeah.
I just want to take this back.
Oh, yeah, you're right. I have two. Yeah. More microphones. There is a difference. Some people are like, I'm gonna one at a time. So I want you to tell me a little bit about yourself, okay? So first of all, just a straw poll. How many people in here are tobacco control related people? Okay, and in tobacco control, how many like maybe work for the county level? Not as many. Where do some of the others work for? UPM, which is hospital system? Okay, great. What else? Anything else? State Department of Health? Okay, great. Anything else I didn't cover? How many people are direct, like, cessation providers? A few. Okay, how many people are educators? Okay, about half each. Okay, great. What about how many people are HIV service providers, some nature? Okay, excellent. What about mental health Oh, really? More than I thought. What about substance abuse? Okay, excellent. What about people who are in the academic arena? And this can obviously overlap with all the other options. Yeah, what about people who've raised their hand for everything I've asked so far? Oh, it's you? Okay, got it. All right, you're the man of everything. Well, we're going to hear from him a little later. Who haven't I covered so far? Physical health. Excellent. Yeah, that's right. That's right, we have bodies. Okay. I've never thought about mine as a trans person. Never. That could actually be true. But anyhow, okay, so physical health providers. Okay, excellent. Anything else I haven't asked for? Yeah, administrators. Policymakers. Insurance. Anything else? Somebody hasn't raised their hand yet. Who hasn't raised their hand yet? Was that? Yeah, you're just you. No, what are you? Community Center, excellent. Which one? Excellent. Washington County Gay Straight Alliance. I love that. How many community centers do we have in the state? 7. That's actually a lot compared to a lot of states. That's really great. So you got a good basis. All right, so let me, well, as Amy had said, it's great to know if people had any questions or things you want to know about specifically. Anybody right now, from all the stuff that you've taken in so far, because I'm a good catch-all person, anybody have any things that you're still kind of like thinking about or struggling with or wondering about, or it occurred to you overnight, or questions or comments even after yesterday's stuff? Yeah. Yes, it's you. Oh, yeah, you're right. You need a microphone. I'll stay away.
So whenever I go to conferences, this question usually comes up for me is that the people that are in the room right now are the people who want to be in the room. So how do we take this to the people who are not in the room or are not here, or kind of how do we navigate that, I guess, or how do we build on the momentum that we've got here?
And that's a great question. So that's actually, we're going to do that as a whole big section of this talk, is we're going to talk about some of our planning, what we can do to take away from this. Yeah. Someone's running to you right now. Hold on a second. All you have to do is raise your hand and someone will run.
The thing that in my practice that we are having trouble with is finding somebody to do our surgery, our penile-ectomies. We are sending so many people out of state, which is a big cost because we cover it. Why can't we find somebody here in Pennsylvania to take care of this? I mean, we do the hysterectomies, we do the mastectomies. Why can't we get our men taken care of? We can get our women, but we can't get our men taken care of.
Yeah. Are you actually saying the trans, just let me ask a question. Are you actually saying the trans women who want surgery you're talking about,
No,
or the trans men who want
the
surgery?
penile-ectomies.
Okay, got it. So phalloplasty, things like that. You know something, I will say this. You know who else was also struggling with that issue? New York City. I know. So you kind of get a sense that New York City's got a few doctors, got a few welcoming people, still didn't have, they didn't even have a surgeon who was doing top surgery in New York until like last year. And top surgery obviously is something that people have a lot of experience in. We're not even talking about something like a phalloplasty that's much more complicated and you wouldn't get the experience in. You'd have experience in top surgery because you do mastectomies, things like that. You may not have exactly some of the reconstructive experience, but it's pretty similar. So I will say that while it's there's some battles you can choose to fight and some battles you can think that may not be for today. You know, New York City was able to get it, but it's really because people were lobbying individuals. And the hard thing is even when you lobby individuals, from the perspective of a trans person, do you want to be one of the first trans people to go to the doctor who doesn't have a good experience behind them, right? Like usually what we do when we go to doctors is we look at the portfolio of all the work that they've done so far, and then there's a lot of destination trans surgery in the world even. Sometimes people go to other countries because it's cheaper and it's not covered here. But often if you have the chance of it being covered in the United States, it's really common. I mean, there's a place down in Florida that just has a boarding house for all the people that they go to kind of thing. And that's not unusual because destination surgery for transgender confirmation surgeries, we don't usually call it sexual reassignment, we'd say gender confirmation. Because we want, if it's something that people aren't very experienced at, we want the absolute best we can get, and so people make those decisions. So you can continue to individually ask people, but I suspect that will be a slower uptick because it's a challenge in a lot of places in the country. Yes?
Are you talking about Pennsylvania? There are surgeons in Philly and New Hope that do it. Okay, there's 2 or 3 that some people love. So it certainly wouldn't be for everybody. There's also folks in Ann Arbor, Michigan, so it's out of state, but kind of from, if you're in the Pittsburgh area, it's kind of equidistant. Yeah, so just to let you know, there are people in Pennsylvania.
Okay, so one thing I'm hearing out of that, and we had another question over there, I think, if I'm correct, but one thing I'm hearing out of that is that even as the people who are actually working with the population, it's hard, you don't have a place where you can kind of like swap what resources are available in the state, right?
There's not a big registry.
Okay.
I mean, you can Google stuff, and you can Google surgeons,
Right.
and you can Google Transcare Pittsburgh, and we all pop up.
But it may be hard even for the willing providers to figure out kind of what the best resources are in the state for medical care. Yes.
So Scout, he channels me sometimes, and he's done it again. So I want you to really think big. Dr. Levine was here. She showed you that Governor Wolf has a work group. Corrections is on it. You're VA, aren't you? Aren't you working with veterans? Okay. So we can think big. We need to be thinking about, she's already done some policy changes. She can help us with this. It's not out of our vision. What we plan to do, the thing about what happens next is so important. Number one, when we saw that we had to shut down registration 3 weeks after Save the Date, we said we need to record this, first of all. But we also need to have a plan of what are we going to do next. And so I've already had some meetings, and one of the things that we're looking for from the Department of Health is, instead of forming yet another work group, we're going to allow you to help us prioritize. We have 8 regional primary contractors. We have the ability to do incredible pilots. You heard the story of how this happened. And pilots work because we have an extraordinary evaluator that is always with us in the beginning, during whatever we're piloting, and after. And we do both process and outcome and make sure we tweak it so that we can move it across the Commonwealth. So as Scout continues to lead us forward, think about what you want to happen where you are and what would work in your service area, and raise them up so that we can prioritize, use our regional primary contractors to help pilot some really strong initiatives, and also be thinking about Dr. Levine. We have an incredible pathway to her. She is engaged. You heard it yesterday, so is our deputy. And we need to ride that now. Now is the time. Thanks, Scott.
Absolutely. I'm not going to take that. Yeah, I would love someone with a computer. That's what I was doing with my hieroglyphics earlier. Okay, great. So I have a few notes on what I wanted to talk about. I hope you don't mind if I jump to note 4 for just a second. I'm going to be a little out of order. Hopefully you won't notice. Okay, ready? Yeah. You're talking about what happens when you're providers and you're kind of experts, right, in the first place. What if you're not a provider and you're in Pennsylvania right now? So what if I am a trans guy? Well, I am. But what if I was a trans guy who lived in Cranberry? Is that where we're in? Cranberry Town. Okay, Cranberry Township. All right, great. Can you do me a favor? Can you just find me what the local hospital is? Yeah, no, it doesn't. That's okay. I would take a while with the spelling. It's fine. That's not an issue. This is about outcomes, not process. Okay, Passivant. Let's try that. UPMC Passivant. Great. Do me a favor, just search transgender. Ready, Passivant? Does anybody work for Passivant? You guys ready? This is your moment. Excellent. I love it. Look, I can find something related to me up there, right? And then Western Psychiatric Institute. Amy, that's your place, right? Good job. Excellent. And then sexual orientation, too. I even find something related to youth. I absolutely love it. Okay, go back. Let's find another hospital. what is, do we have any? Northwest, that's another one, Northwest. Well, UBMC is the same thing as Passavant, it seems like. So there was another hospital called Northwest something or other, I don't know. I think it was a UPMC facility. It could be? Okay. Okay, let's find UPMC Northwest Hospital. Excellent. Let's just try it one more time, see if the same stuff comes up. We'll be all good. Yeah, it is the exact same thing. It's the exact same website. Okay, fine. All right, excellent. Then, okay. Okay, maybe I'm somewhere else in Pennsylvania. Well, give me a chance. I drove somewhere else, and then I got sick. How's that? Great. Let's try it again. Oh, that didn't work as well. Does anybody work for Allegheny Health Network? Yeah. All right, so there's a couple action points we can take it away for those two people. We won't keep doing it, but I will say this. Every time I do this in front of anybody, the chance is I never even have to go to a third hospital before I find one that has absolutely nothing up. And if we're going to talk about like the principles of what might create a welcoming environment, the first principle is actually that there's going to be tailored outreach. But the second principle would be that when you go to the agency, you find welcome somehow, somewhere. And let's just be honest. I mean, our web presences are an important, stake that each of us have in the professional arena. And it doesn't usually, like this hospital probably has, 200 web pages up about itself, right? In all of those web pages, there's not even one mention of the word transgender whatsoever. And that being the case, it's also a really easy thing for all of us to do to actually not just even have mention of the word, but have a special sub-page specifically aimed at the sexual and gender minority populations. So that would be LGBTQA, AATTST. Sexual and gender minority is sometimes a faster way to say it. So as we talk about the providers having challenges figuring out how to share resources, think of it one step differently and consider what may be happening from the perspective of the consumers, the ones who aren't the experts like all you, trying to figure out what to do, where to go. So let me just ask of the people in the room, for the agencies you work for, how many of you know that you have something that's SGM welcoming on your web presence? Well, that's less than half the room. Okay. So while we might be starting to make changes, and the truth is we are making a lot of changes, and the truth is Pennsylvania is ahead of many other states in the country, absolutely. It sounds like we're hiding our light a little bit, and we're not yet getting it to the point where the people outside can even start to understand the commitment that we have in this room, the commitment that we have to carry it to other people, but the commitment we also have to make sure that the public and the consumer population understands our welcoming. So I'm going to put down, let's see, we have 3 things already. Can someone actually take this down as a possibility, since I'm not great at writing here? We have a potential mentor program. We have a way for people to share information who are the providers. And then it sounds like we also have a potential, well, we have an action item for Allegheny. But maybe, though, Allegheny is just an example, because it sounds like we have an action item that's very similar for most of the agencies in this room, that you don't know if you have anything that's SGM welcoming on your web presence. And that definitely is something that is the very beginning start to make sure you're welcoming. Who thinks that if they went back to their agency and asked for it, they could get something welcoming up on their web presence? Can I ask a question? The people who don't think you could, can I hear, and I know you had your hand up, so just a second, I'll get to you. Can I hear what you think the barriers might be? Because that was still less than half the room. What do you think might be the challenge with getting something up that's welcoming? And be honest, it's just us. And the camera. But you know what I mean. Anybody? There obviously were barriers because a lot of people didn't raise their hand. Yeah, go ahead. Good. Thank you, Allegheny. Well, that's a great point. You know, I have an interesting example from, of all places, rural Missouri, with the Veterans Administration, as a matter of fact. There was a small fish there. It was a nurse. She had no official connection to the LGBTQ communities in her life, but she started to treat LGBTQ people and was really moved by the circumstances and experiences that she dealt with. And that nurse, who was not very high up in the hospital system whatsoever, decided she wanted to change what they were doing. And the truth is, she just became the bulldog that you are for other people in the medical system. And she kept going back and kept going back. Luckily, there's data that can back you up related to the health disparities, related to the need. There's great data here related to the people's fear of doctors and things like that. And she was able to take that data like that in with her. It wasn't even as good as what you have here. And she kept asking administration again and again. And the truth is, what ended up happening as a result, as a matter of fact, is that her whole hospital system created an LGBT liaison system, committed to have all of their people trained, and committed to make sure that they did also have an LGBT welcoming page up on their website. And this is, remember, the Veterans Administration is part of the federal government. So, you know, not necessarily the most competitive. Like, they know their people aren't going to some other hospital, right? You know what I mean? And so I would say this, that, you know, something, I'm a trans guy who, I deal with the people around me who are in my community having such incredible health challenges, including the fact that we talk about suicidal issues for trans people. Let's just be honest. It doesn't end when you're a teenager. I know way too many middle-aged, nationally prominent transgender leaders that I keep checking in on to make sure that they are not tipping over the wrong edge of being suicidal. The weight and accumulation of years of dealing with this kind of stigma and discrimination is really intense for people to deal with. So as I'm surrounded by that, and I, you know, do as much as I can in the world, considering that functionally my wings have been clipped because of social opportunities and things like that, because of the stigma and discrimination I've experienced, I understand as a PhD level trans researcher, I am kind of like a king among my people as far as how far I've come in opportunities. So many of us have had our educations interrupted. So many of us have had our social contacts so cauterized at a young age that we live with such incredible trauma and discrimination. And what I'm saying with that is, you can be our lifeline, even if you're really junior. And I'm using that just as an example, because I mean that about everybody here. So please, we need you. I know that you're a tiny fish in the Allegheny pond, and this is just an analogy again for all the ponds. But please, we really do need you. And tiny fish can make a big difference with a persistent voice. You know, Margaret Mead, it's the only thing that ever has, is those tiny fish with kind of a persistent voice. All right, yes. Okay.
I need to give you a visual aid.
Okay.
You are in a kingdom.
Yes.
Right now. So watch this. How many are connected to UPMC? Look around. Know Antoine and the work that has been done for years and years. And the things that you're saying are all the things that happened long ago. And now you're among champions in the room in the West. So your message is straight on, but you're already in a kingdom.
Yeah.
And you have many experts here that are in need of you showing, and how do we want to say this, Adrian? It's the linkages, it's getting people to think outside the box, and what you're hearing say, wait a minute,
Don't
I
you love the way
connect
Adrian answered
there.
right there? Adrian just answered mentally, telepathically, right to Judy, and she started. No, wait, I wanted you to finish your statement. I'm sorry, I didn't mean to interrupt. Okay, it's the linkages we make and thinking outside the box. Yes.
You want to fight over?
And then we got to.
Can I add too about
Please.
the website question, and to not overly take over the kingdom in Pittsburgh? the other piece is adding to the website, what do we do for the community and who does it? Because, as you said, experts and champions move and change, and so we have that barrier as far as who does it. And so to make it a robust website thing, you have to have somebody quickly take it down if somebody moves.
Yeah, you
So
actually
there's
have
those
to have the
concerns.
resources attached, absolutely. Yes.
So one thing I'd like to ask for, which I am so not good at computers, everybody just laughs, but to have a statewide map, and I don't know how you
heat
talk
map.
about it, but like a statewide map, I live here, who are my providers with the little pinpoints? And then when you click on that little pinpoint, like when you want to go to the Walmart or the CVS or whatever, what's the closest one? Who are their providers there? What insurances do they accept? Stuff like that. What's their phone number? What's their contact info? So in Pittsburgh, we have, and I'll talk about it when I talk, but we have a collaborative of all the providers. Anybody, God help you if you say you do trans care, LGBTQ healthcare, because I'm asking you to be a part of our group and to be a part of our big email group, and we actually have a meeting on Saturday, that we just get together a couple times a year, and then and then as people, we just started this a couple years ago. It didn't exist. Just the people started to talk and said, like, let's get together and talk. So starting from wherever you're at, who else cares about this? Who's the person in my little clinic's administration that I can say, I want to have 10 minutes at the staff meeting. I want to talk about this. This matters. And just get started. So I won't take up the whole thing, but when our boss came, Liz Miller, 6 years ago, she said, who's doing trans care? Nobody. And she said, okay, do you want to do it? You do all this other work. Why don't you do this too? But we're not going to start advertising. I'm going to go start talking to the administration. And she very smartly went person to person, because we were providing, gender services to teenagers and kids. I'll tell you about it. But, she went and talked to everybody so that all the administration was all prepared. She did all this groundwork, which anybody can do. She did it at a very high level at UPMC because it's so big. And then when it kind of rolled out, it was like, well, of course we do. And I was shocked that UPMC supports the Pride Parade a few years ago. And it was like, wow. But people did all that work. There's administrators that found themselves and bought into it. And then they bring it and they work it and bring it into every clinic space now. But that took years. But it started with a couple of people saying this is important. And another thing, I know Allegheny Health Network actually has providers. It's not on the website. Competition.
You gotta
when you
love
pull
it.
up, I was at a
Competition's
conference
great.
and we pulled up UPMC and there's transgender care, and we pulled up Allegheny Health Network and there wasn't.
Yeah, competition,
have
we
it like
love
that.
that because that is very helpful. You've been waiting so patiently way over there. That's okay. Oh, she does one? Okay, great. Excellent. Then I will give this back to you. Sorry. I'm just like a mic hog. I apologize.
I just want to put out a reminder that we have this really cool stream from the pond, and it can be a river, and it's going to be great. But if you aren't an IT person and you don't want to have to put in that ticket and never know what happens, you can go to livehealthypa.org, which is supported by the Department of Health, but the content is reviewed by Penn State, so it doesn't have so many barriers that everything has to be approved by the state and all of that. So anybody can go on there and put on a program that they've had in the past or that they have now in the Healthy Living Practices section, and it can be up and Googleable by July. So, and that also doesn't mean if it goes on forever.
I love that.
if
So
it
it's a workaround.
stops.
If you can't get it on your own site, you can put
Yeah.
your information on someone else's site.
You can put it there, and also you can then, if you're trying to convince decision makers, you can go there and say, like, look, we got to keep up. So use that as an in-between and also just a resource.
Excellent. Yeah, the back there.
Having the pleasure to work in rural areas, I know a lot of times those personal cultures and the beliefs that whole community, I live in Fayette County in a small area, and I know a lot of times even when we address mental health issues, let alone this issue, is those cultural beliefs and those norms that community basically adapted and are not willing to change a lot of times. And I know a lot of times with the politicians, if they're not buying into it sometimes for funding sources and stuff like that, that is a huge, huge barrier in rural areas. So I guess a lot of times even working in the human service field throughout that, you're trying to not only fight the fight for your clients, but also to this political arena that's going on, that we don't want this in our community, or we're not addressing it because we don't believe it's actually happening. So,
You know something, so I have an idea of something that's been done a bunch of other places. I love the fact that since I watch other places, I can sometimes take good ideas and move them around the country. A few of you are talking about things where you kind of need more justification in a way, right? Because even like in rural areas, one of the things that works really effectively in rural areas is, you're right, there's often, there's those beliefs, right? But people also don't want to be labeled as backwards, right? Because they don't want to be, you don't want to be like the West Virginia banjo thing, you know what I mean? So it can, when you talk to people about what cutting edge is, that's often a compelling argument. And then if you talk to them about how many people are doing things, no one wants to be outside the pack. We're herd animals, basically. We want to be somewhere in the center of the pack, not too far forward, not too far back. And so another piece of what could be effective here in Pennsylvania in moving this bar all together might be to also show how many people are already doing these kinds of things. So if that heat map happens with providers, and you suddenly see that there's providers all over the state doing this, that helps be justification for both the places with competition in the urban areas and the rural areas not to be left behind. Another thing that's functionally worked out really, really well, and can often happen even much sooner possibly than a heat map, truth be told, it can happen very quickly after this event, and I say to the two of you because you might make this happen, is a very powerful tool is that people have adopted basically policy standards. And you don't necessarily have to have the surgeon, the state, it's not surgeon general, whatever it's called, physician general, be the one to adopt the policy standards. Experts can basically kind of underwrite and say they support policy standards. So just as another thought of what could happen here is that I was going to talk to you about, basically it's like 6 or 7 principles of what welcoming environment is. 1 is that there's tailored outreach. 2 is that there's visible welcoming for the LGBT populations. 3 is that there's educated service providers. 4 is that there's referrals to community-based and community-specific organizations. 5 is that you do data collection. And 6 is that you promote your lessons, so you're not secret about any of this. We could literally write up those 6 things, and then anybody in this room who has the ability to undersign it would be able to undersign that as like Pennsylvania's SGM welcoming policy standards. And if something like that happens, and literally, how many people in this room would have the freedom to, not just saying you're doing it, but would have the freedom to be able to sign something like that as an individual, not representing your organization, just as an individual, not representing your organization? All right, so we've got like 20 people here that are raising their hands. If we were to say those are like the 6 principles, sorry, I need to do my counting. You'd be surprised that I actually got a degree in mathematics, considering I can't get 6 and 7 figured out very successfully. If we were to write those 6 principles down, then it looks like you could have about 20 people here who would at least have the freedom, if they agreed with it, to be able to undersign those. And then that's been used really effectively. It's actually the basis of what we use for our state tobacco best practices. We originally just got experts together. We wrote down the common sense things. They agreed, and those ended up becoming, later we had a whole evidence basis for everything like that. But if you had like a statement like that undersigned by a bunch of experts, then that's something that you can take as great justification. You can take, in the rural areas, as great justification as to why a website as one of these principles is just something we should move forward towards. So we're putting that down as one other idea, and that's actually one that the way it's been done in the past, you don't even need to go through a lot of channels. It literally is writing the piece of paper up, circulating it to the room, and seeing who says yes. Then you can put it out.
It's what we did to make the churches affirming in Pittsburgh.
How'd you do that?
We did the same
Oh, sorry.
thing. Sorry, it's what we did to make the churches affirming in Pittsburgh. We had a group of people with an interfaith meeting at the GLCC. They sat down, agreed in terms of how to be a welcoming congregation, and then suddenly we started seeing it everywhere, and it shifted the split of between the affirming churches and those who weren't.
Right. I mean, the truth is we don't want to be left behind, right? And this gives anybody who's trying to be the advocate, the little person advocate in a big pond, more justification for how that advocacy is supported by actually a bunch of people, not just you and your wild hair thoughts kind of thing, right? Yeah.
And Scout, I'm back again. Do you remember Dr. Robinson speaking yesterday?
Yeah.
And she went down through the list of the populations we recognize as disparate populations, tobacco-related health disparities. The reason why she held the last part out and talked about LGBT is because we've had conversation and she gets it. We represent every disparate population.
Across all the groups.
And there are others who see us in a very narrow space. We're not narrow, we're huge. We have learned through our coalition pact, Pennsylvania Alliance to Control Tobacco, because of this huge commonwealth, if we speak in one voice with one message, we are so powerful. So you have the ability in this room to help us define those priorities so that we can help you and us speak in one voice with one message and make things happen. This cannot stop here. And I know that together we can have a lot of power. We have more people speaking today that are going to motivate you and help you find those linkages. So really, Dr. Scout is giving great information here, but think about our Commonwealth. Think about the rural parts. Think about, the 3.0 innovations. I was in Fayette County, and that program is working with the rural counties through another funded position to help counties, smaller rural ones, bring people together and say, what can we do for our county? And it started with the opioid. We need that Narcan in rural Fayette. Where is it? And yet, we went back, and a woman from Cambria County who worked in education formed her own coalition, unfunded, 66 people, and has done incredible things in Fayette. That can happen. We can embed these things in these rural counties. It can be done. The models are there. Keep thinking.
Y'all are going to get tired of hearing me.
We're getting a bias from the front end of the room, though. So I'd
Yeah,
love
I
to
know.
comment on the back end of the room. Let's keep getting the back end more, okay? Did you have your hand? Go ahead.
One quick
Yeah.
comment was, we need to tap into the networks that are actually there. Why isn't Department of Health and county extension agents working hand in hand? Because, no, not that. But seriously, that's how you break into real rural communities. Go to the 4-H fairs. Go to the county fairs.
Yeah. You're right. it
Promise I
absolutely
won't
makes
say
sense.
anything else.
No, that's fine. I just want to make sure that people in the back of the room also feel good. Can I just say, if we want to do that policy statement, I'll be happy to help you write it, and then we can circulate it to people here. Does that seem like something you'd be on board with? I think we're certainly willing to take it. Okay, I think that sounds excellent. We can go ahead. Yeah.
Talking about rural areas, I know there's a number of federally qualified health centers in some of the rural counties, and I know there's a Pennsylvania Community Health Centers Association, and I'm just wondering if there's been any attempt to reach out, or maybe they're already doing this, I don't know, but it seems like if we want to get into some, not all the counties have one, but a number of them do, and that seems like that would be a place that since they do serve the medically underserved, then they need to be LGBTQ friendly.
And I worry a little bit sometimes that when you hear things like Adrian's project, you think to yourself, well, someone's doing amazing LGBT work in this state, right? But we've got how many thousands of medical interactions that happen on a daily basis, right? So it really is the case that if we're going to make this happen, we need to have a concerted effort. We need to support the people who are the experts who can do the biggest behavior change, but we also need to make sure that every front has some kind of an open door, right? Because people can be turned away everywhere.
So one of the things that we forgot to mention earlier when you were asking about people's employers or their positions is funders. So I'm here as a representative for AIDS Free Pittsburgh, which is the fiscal agent for that is the Jewish Healthcare Foundation, which is my employer. So I do think that there's a lot of foundations in our region that would definitely help with this, even just as a voice or to sign on to something. I mean, I'm not going to speak for all of them. I know that we would do this, but if anybody wants that information, they can see me out. I have a table out there, and I can help with any kind of coordination of that. We also have 21 partners on AIDS Free Pittsburgh. All of those people would definitely be willing to help in any way that they can. And then we also have a regional collaborative for our HIV serving providers, and they would definitely be involved too. So we have a lot of resources and groups of people that would definitely be helpful in navigating to figure out how to best form some kind of other coalition, or at least assist in figuring out what the best ways to do that would be.
Right, so maybe can form that heat map, or possibly fund building of the heat map, or possibly sign on to the policy statements that come out that help other people move. I think that sounds amazing.
And we also have 10 interns this year too. So
Whoa.
we do every summer. We usually have 10 to 12 interns.
Can we just have 8 of them? Would that be all right, just for the SGM issue?
Right. But
okay, 7.
We can always, figure out a way to put them to work too. So.
Yeah, that sounds amazing. We actually, another Missouri project that I did was, that I did technical assistance on. They did it. I don't do anything useful. I just talk to people. But they did it. Is they actually assigned someone who was kind of junior level to the hospitals, and they looked at the hospitals to see who had welcoming information on their websites. And then they started sending them letters and basically saying, oh, by the way, we see that you might be out of compliance with the Joint Commission's non-discrimination for LGBT people. We would hate for that to be the case, right? And, if anybody works for a medical provider, when you say Joint Commission, they all just kind of like, hertra, because the Joint Commission can shut your doors faster than anybody else in the world. So, so they say that, we don't seem to see that you're in compliance with this Joint Commission requirement, so can we please help you? We would love to be able to give you some information on how to promote that you're LGBT welcoming and that you're non-discriminating. And the interesting part is, with a pretty junior level staffer, in 6 months worth of effort, they actually went from being 30th in the country in welcoming hospitals to 6th in the country. They actually got over 40 hospitals to start to publicly promote being LGBT welcoming. And the amazing thing about that is they would go up a hospital chain, but you know how the medical world works these days, right? They'd be like, okay, we'll change it. We happen to control 8 hospitals in 4 states. So, you'd go up, and the next thing you know, it would branch out all across that. So that's another program that we have very well documented that was honestly roughly an intern level program, and it had a huge change in the kind of acceptance that people had around Missouri as a result. I love the ideas. They're all great. Keep them coming, and I know that we're writing them down. Okay, I'm going to just ask us, from what we learned, so what are the big health issues for the LGBTQ communities? What do we got? You shush up. The 2 of you shush up. We're going to get there. Acceptance, absolutely, no question. All right, well, they said tobacco. Okay, they did. What else do we have? Yes. Obesity. Cancer, yes, absolutely. Higher risks for all those things. Mental health issues, yes. Addiction, yes. I'm sorry? Okay, addiction, yeah, absolutely. Basically, if there's a way that stigma and discrimination can push you to stressful activities in the LGBTQA populations, it has done so. Out of the populations, did I just lose my stuff? Out of the populations, who are the most at risk? Transgender people, yes, absolutely. Had the highest risk profile of all the different community subdivisions. People of color, absolutely. Whenever you have any kind of a dual stigmatized starting point, you're unfortunately going to suffer more as a result. Youth, immigrants, undocumented immigrants, absolutely. You're still missing at least one of the big populations. Elderly and handicapped, yeah. Anybody who's already dealing with issues that may have to do with stigma. What's the largest population of the LGBTQA, TST communities? I'll say SGM. What's the largest group? What was that? Gay. Who else? You betcha, baby. He's already been trained, so it doesn't count, right? He's an expert on it. I would like all the people who give trainings like this to shush up and let everybody else talk, okay? It is bisexuals. Bisexuals are half of the LGBT population. Now, the odd thing about that would be, do we hear as much about bisexuals? No. Why is that? We experience stigma from within and without the community and outside of the communities as well. So I just want to encourage you as you talk about the work you're doing for outreach, that you're going to be hitting more bisexuals than any other group. So if you're not talking about bisexuality in your materials, in your outreach, in your promotion, you're missing the biggest population that you're talking to. And you're also missing a population that is also more unstable. Transgender, bisexual, and then lesbian and gay as far as kind of the stability continuum, because we get ostracized from within and without as well. So it leaves us with fewer places to call home, and obviously more social determinant issues related to health. No question. And then, another thing that I want to talk about as far as a big health issue we have is also isolation. I actually think it might be one of the issues, that may be one of our defining issues, but we're not talking about it very much. And, in the social science perspective, from my sociology hat, just think of it this way. We usually consider that people have social support from 5 domains of their life: your neighborhood, your work, your birth family, your friends, and who you live with. Now think of your average trans guy. Do you have support from your neighborhood? Not very likely. And if you do, tell me, I'll move there. Do you have support from your work? No, actually, like for example, the trans discrimination at work is huge. DC did some resume testing where they sent off matched resumes. One said that you were trans, one didn't, but everything else was identical. And they found out for people like me, 60% of the employers did not even call the trans person back for an entry-level position. It's a huge level of job discrimination, huge. So do you have them in your work? Not very likely, right? Okay, what about your birth family? How you doing there? It's a great point, sometimes. Yeah, and it's interesting because Amy, as she talked about the story from her mother, I also have a story from my mother, and how my mother also didn't talk with me for several years, and clearly had a hard time with me even a couple years before and after that. And finally, a few years ago, she finally told me. She said, it's because you're trans. The only thing that's odd about my story is that my mother's a lesbian. Yeah. And yet it's really true. That, the level to which we get exclusion, there's so many layers of it, right? There's so many layers, like, how white your skin is, how well you speak newscaster English. There's so many layers, Are you Jewish? And we're celebrating only Christian holidays. We all have so many layers to our own identity and our own feelings of whether we belong or we don't belong in this world. If you're a light-skinned Puerto Rican and you're a dark-skinned Puerto Rican, trust me, there is a difference in your walked experience in this world, right? Yeah. And so in the same way, there's lots of layers even within the LGBT community. So my mother was delighted when I originally started to identify as lesbian. But then when I came out as trans, I lost my biggest supporter, and I lost her for years. And I also didn't even know why. I just knew that we weren't talking. So there's just so many different layers of how these things can affect us. Okay, so birth family, then what about your friends? Hopefully you have support from your friends, right? Because if not, you need to get different friends, right? So hopefully you have support from your friends. And what about then the people you live with? Hopefully you have support there too. If not, hopefully you move out, right? But that means out of the 5 domains where you get social support in this world, LGBT people may really be missing support in 3 of those domains. We had an interesting way that this played out in tobacco cessation a while ago, because as I was training cessation service providers, they were talking about some of their experiences in talking with the SGM population. One of them was this guy who's they're like, if you go to the bar every night, honey, you can't keep going to the bar if you want to quit smoking, because that's going to kill you, right? You can't go back to the place where you smoke all the time. This was when they could, well, you can smoke in bars here too, I guess. In most of the country you can't, so that's unusual. And he actually got back to the cessation provider and said, I can't stop going to the bar. You don't understand. I cannot stop doing that. And the provider was sitting here telling me, like, what is he, an alcoholic? What's the issue? Why can he not stop going to the bar? But if you look at it in terms of where that person gets their social support, then it becomes more clear, right? The bar is one of the fewer places in the world where he feels welcome and loved for who he is, and he's not getting it in other places. So I just urge you to also think about how this level of kind of cumulative social isolation plays itself out in our lives. I do think that in the SGM population, we have much more isolation, even among the people who might look very connected, than we suspect there is. So another thing that I would also just urge us to think about, like the mentor programs are a great way to do it, that this isolation really is something that we know that if you have more friends, it's a safety net more powerful than anything else in the health world. And the SGM population may be missing that safety net more than we realize. So it's another way that we need to hopefully get these connections and put them together. Okay, so of the LGBTQIA population, how many are there in the state of Pennsylvania? Any ideas? 346,000? Really? Someone gave the answer yesterday? Oops. Oh, yeah, you're right. Oh, you know something, baby? I'm going to say, I know him too well. That's the problem. I'm going to say you undercounted that one. Did you say 346,000? Yeah, because I was using the Williams Institute. So am I, but 3.3%. 410,000 is what I got this morning. 410,000, which is the roughly analogous to the population of both Pittsburgh and Allentown put together. Out of those 410,000 people, what do you think of when you think of like the top SGM health issue? What's the most obvious one? HIV. Trust me, we think of that too. We really do. But you run the numbers, we do the epidemiology because we're in public health, right? Actually, we have over 3 times as many people being affected by tobacco as HIV. Yet how often do you hear that tobacco is one of the priorities? The truth is, we currently have equivalent to the population of Allentown, Pennsylvania. That's the number, it's about 110,000 of sexual and gender minority people who are going to lose years of their life because of tobacco. The same number as live in Allentown, Pennsylvania. And the reason why I say that this is important for you all to know, you might have figured it out a little bit with like the title of the conference, but it's because we don't know it as a population. So if we don't know that tobacco is our biggest health issue, then who do we look for education on that subject? The health communities, right? So that means that we often don't understand the level to how it impacts us, and we're looking to you to please educate us on this point. As Adrian had said, if you do any needs assessment, and they did, 6 of them here, something like that, of the SGM communities, we put tobacco as usually 9th or 10th in our priority list. And yet, in the public health world, it's number 1. Run the numbers, it's number 1 by such a huge margin. So unfortunately, that's a message the tobacco industry would like us to keep saying, that it's 9th or 10th, right? And that's a message that as the tobacco control and public health community, we have to make sure we counter. Let's talk for just a couple seconds also about HIV. So HIV, we started to find out in about 2007 that HIV, oddly, is it a risk factor for HIV? I'm sorry, is smoking, is smoking a risk factor for HIV, yes or no? It is. It's an independent risk factor for seroconversion, is if you smoke. Then we found out, actually, that it's also an independent risk factor for conversion to full-blown AIDS. Then we found out, actually, that people who are HIV positive, if your meds are stabilized, the number 1 thing that is a risk factor for your life and losing years off your life is smoking. So we have, and then also actually as the CDC started presenting a few years ago, they basically told us that there's a synergistic effect, unfortunately. They're like friends without benefits between HIV and smoking. And it's not a total surprise, right? Because smoking affects you on a cellular level, and it's an immunodepressant for your whole, it's a circulatory depressant, everything like that, for your whole body. So it's not a surprise to think that if you've got something affecting your whole body like HIV, and then you've also got smoking, that they're going to interact in a bad way. So basically, if we've got someone who is an addict who is HIV positive, are we willing to treat their addiction? Yeah, we think it's really relevant to stable care for that person, right? And yet the odd thing is, Too often in HIV programs, we're not yet treating their smoking. And yet we know from the numbers, again, from the public health numbers, that smoking is going to kill them faster than any other issue they're dealing with. So it really is one of those phenomena where we have to look at how smoking weaves itself into the fabric of everything else that's happening, because its impact on our communities is here, and yet the messaging around what the impact is way down here. And the people in this room are the ones who can fix that messaging. All right, I've got 8 minutes left, 7, 6, 5, 4, 3, 2, 1. I want to switch us back a little bit to some more of our action items. So this is a little bit of an open forum for you right now. Think about what you're doing in your organization right now. Either ask a question or suggest something that you think might be able to happen in order to move your organization forward, or to think big on the whole Pennsylvania end as far as what can move us all forward. We've got some ideas that already came out. What else can we come up with in the next few minutes that might be able to be something we can take and move forward to help healthcare for all of us? That sounds great. Who has worksite policies for tobacco-free work sites? Who does not? Okay, so can I use you as an example? Is that all right? Sure. Do you think that it'd be possible for you to suggest something like that at your worksite?
No.
So tell me why. Thank you for the honesty.
So I work in housing and homeless services. I'm a licensed social worker. Most of the people I work with work in a very similar capacity. And I would say at least half of our staff smokes.
Oh, really? Yeah.
It's a very high-stress job, and we are a harm reduction organization. So they've made a lot of efforts to move smoking areas away from entrances, to publicize, cessation efforts, to support all of our clients in cessation efforts if they want to, and staff as well. But getting to the point of actually taking away smoking areas it's been brought up in the past, but is very much fought against. I've worked for this organization for 2 years, and I've quit smoking probably 5 times in the past 10 years.
Well, on average, you may still be smoking because it takes about 7 on average, so just understand.
And there are a lot of staff who express that they would like to quit smoking, but the general atmosphere is just very difficult to do it in. So I think it's a lot of both. We don't allow ourselves to take breaks unless we have a reason to. So using the smoking break as kind of not a crutch, but forcing yourself to take a break and breathe a little bit. But I think that from the pushback they've had from staff in the past, that implementing a full smoke-free policy would just be incredibly difficult and drawn out and most likely not effective in the end.
Okay, so it's a great example. Okay, there's an environment where smoking is really, really entrenched. We know these. I was driven a little crazy when unfortunately my middle son had to go through addiction treatment earlier this year, and he came back free of drugs and a smoker. And I talked with him, and I'm kind of like, you have your smoking area on the patio right outside the door in the only place with chairs. Can you possibly move your smoking area to at least, move it way over to that other outdoor patio, or move it out there where there's no chairs, or move it somewhere where it's not the prime location in your whole area? And of course, they also, they pushed back on me too, as well. But can I ask, is there anybody with experience who's been in one of these high smoking environments, addiction, homelessness, something like that, where you've been able to get a better policy passed? And we're talking harm reduction, so we're going to stay even a better policy. Like maybe it's move it farther away, something like that, steps like that. Has anybody had experience? Yes. Was that a yes? Go ahead. You found him. He didn't want to talk. You're like, I don't care.
That's
Good.
only because she pays part of my salary.
Okay.
And she also counts as my 4th work wife. So.
Yeah.
I'm Mark Rogowski with Pittsburgh Mercy. In February of 2015, we took our entire agency smoke-free. In June of 2012, in fact, last week we celebrated our 5th anniversary of our first site that went completely smoke-free, which was driven by the consumers as well as the staff. It was a step down from being hospitalized. Some of these folks that came in hadn't been smoking, and now the only way they could get outside was if they were a smoker. The staff and the consumers agreed that they needed to change that. They worked together along with our cessation staff with creating a plan, and over 4 months' time, created the policy for that site, and then other sites followed suit that broke down how many smoke breaks they took, and changing those smoke breaks into health and wellness breaks. And February 1st, 2015, all of our sites, which is close to 80 when you consider major buildings as well as group homes, couldn't smoke on the grounds, couldn't smoke in the buildings, and we instituted a smoke-free work shift policy, so all employees could not smoke during the workday, and knock on wood, no one's been relieved of their duties as of yet. We do know some of those that sneak, but it was a long and arduous path, and now we work closely with Tobacco Free Allegheny, working with the Allegheny County Housing Authority. Over the past 4 years, have been taking all of their sites smoke-free, and now we're in the home stretch with them, working up to HUD's piece.
So Tobacco Free Allegheny, can you, because it sounds like this, you might be a great home for this. I mean, I love the way we have our answers in the room, right? Yeah. We have so much knowledge around how to do these things. Y'all don't need me. You have the answers here in Pennsylvania already. It's just a question of kind of like being able to share the expertise and figure out, like the wellness breaks, I think is a great idea. Plus, you're right. If you have no other urge to take a break other than a cigarette, I'd probably want to smoke too, right? You have a stressful life. So creating an environment where people are encouraged to take breaks for wellness, not necessarily cigarettes, is a great kind of shift. Are you Tobacco Free Allegheny?
Yes, I am.
Okay, great. Then can you all think about how you can take that expertise and put it in a position where she can access it? I'm sorry, is your pronoun even she? I have no idea. Where they can access it.
Absolutely. They can reach out to us. We work with Addiction Medicine Service, and we'll come and we'll work with your organization to create a worksite policy. We'll talk with you about what is already included in your worksite policy, what you can add to your worksite policy. We have, as Mark was saying, we have experts with us that we can talk with, people that have done it, that have the experience, that can talk about what worked for them, what didn't work for them. Seal Victor DeSando isn't here, but she's a great resource as well. We call her she's got a Google ability that is incredible to find articles that will also assist you and talking to your upper echelons of your organization as well.
It sounds great. Okay, thank you for being, and I'm sorry to have gotten your pronoun wrong as well, thank you for being our example person here. I really appreciate it. We've got, go ahead.
I had a question.
Yeah.
You said tobacco is high for the health of people with HIV.
Yeah.
What about secondhand smoke?
Absolutely, just as bad. I mean, not even counting the fact that tobacco for, like trans people is horrible for surgeries, as a matter of fact. I was urged to say this, that if you're in the trans community or near the trans community, you've probably heard the stories of people having phalloplasties that did not work because they were smokers. You follow me as far as what that means? Your penis dropped off. Yeah, exactly. If only we could use that as advertising, right? Maybe fewer people would smoke. Or we have examples of trans women or trans guys where your nipples also dropped off. If only we could use that. We'd probably have fewer smokers, no question. But secondhand smoke is just as big an issue. Both of it affects you on the cellular level. I remember with the Surgeon General when the last report came out on smoking, she literally stood up there and said, I cannot promise you that if you walk by a smoker once, you will not get cancer. We've understood that the impact is that big of tobacco smoke. It's just that toxic, unfortunately. Scott, one more time. Yeah.
Yeah, just a quick, all right. Well, I'm Antoine Douay. I'm an addiction HIV psychiatrist, and overseen the addiction medicine services for many, many years. What I wanted to mention, we talk about really the change of culture and policies.
Yeah.
The example is Western Psychiatric Institute and Clinic, which is our psychiatric hospital, the psychiatric hospital of UPMC. You know, in 2007, prior to the Allegheny County ban, you know, the smoking ban, prior to that, so we're talking about prior to 2007, you know, inpatient units, we have around 300 beds inpatient, you know, at Western Psych, and we have very much specialized units. We have a psychosis unit, we have addiction floor, eating disorder, all these units. There were, prior to 2007, patients were allowed to smoke on the units. They were given breaks, at least 4 or 5 breaks a day.
Hospital smoking, kind of confusing,
You know.
but it still happens in a lot of places.
Yes,
Yeah.
and it obviously, I started working at Western Psych in '99, and I fought this whole thing, you know, from early on, and I was not successful at all. I mean, even with other people who were great champions, advocates, you know, to really change the policies.
How'd you do it?
Well, we waited for unfortunately,
Oh,
you
really?
know, we had
Okay.
to really wait so many years for that
For
ban.
legislation.
And legislate, exactly. But you know what happened is the UPMC, some of the leaderships were attempting to get a waiver of the ban. And in fact, you know, I say it very openly, I threatened to quit. I
Really?
said, if
Wow.
you get the waiver, you know, because, you know, obviously the concerns were, well, we're not going to have patients being
Mental
willing
health
to get
institution,
admitted.
another big, yeah, smoking
What are we going to
environment.
do with patients who are going to be smoking? And what if we're going to have patients who refuse to come into the hospital, get treatment because they know they cannot smoke? Well, you know something? No, that is a total BS.
Because
It
there's so many
doesn't-
people fighting to get in the mental hospital
well,
that they
yes.
might
Well, you
be
see,
like, oh,
but,
no,
but,
no,
but
no.
the misperceptions were that there's going to be rioting, people are going to be getting crazy and aggressive and
You
everything,
hate when
which is
the
total
metal,
misperceptions.
when the, you know.
And I'll tell you, something with obviously the tobacco-free Allegheny with SEAL, Victor DeSendo was really very much also involved with us. We established a task force, and what worked is a grassroots movement. Is this what it is? This is how people change, and we were assertive, aggressively assertive in the approach, because there were some concerns. What are we going to do? How are we going to come up with really the nicotine replacement, approaches and everything? We put together, very good system. And in fact, the whole really Western Psych was transformed from that aspect. And since 2007, I mean, you're talking about really, seeing a major change in how, not just really with the patients, quitting smoking, and providing, nicotine replacement, and counseling, but we're talking about staff, that this whole thing about allowing staff to go on these breaks and go out and smoke and come back smelling tobacco and all this, and so it does work. If you really work at it, and you are aggressive and you advocate and you believe in what you're advocating for, I do strongly believe it does work.
You can even part the biggest
You can make a
Cs.
change.
Yes, exactly. All right, excellent.
Thank you.
We are out of time, so thank you very much for all of your ideas, all your planning. I look forward to getting the reports on what you've done to actually change this as we come back again next year, right? Because we're going to make it annual, right? So go forth, make a huge amount of change, make me proud, okay? Thank you.
Can we get one more round of applause for Dr. Scout, please? Thank you so much.